You're listening to Who Said Guideline Lifeline, a deep dive on the latest cardiology guidelines, the evidence that support these recommendations, and how they differ from prior recommendations.
Yesterday, the American College of Cardiology and American Heart Association published the 2025 Guideline for the Management of Patients with Acute Coronary Syndromes. What do you need to know? The document is packed with valuable information spanning 72 pages, excluding references, so I want to break it down for you today and highlight the most important changes you need to know about for your practice. The 2025 ACS Guideline updates recommendations from 5 previous guidelines. The 2013 ACC AHA Guideline for the Management of ST Elevation Myocardial Infarction, which I will be referring to as the 2013 STEMI Guideline, the 2014 AHA ACC Guideline for the Management of Patients with non-ST Elevation Acute Coronary Syndromes, which I will be referring to as the 2014 NSTEMI Guideline, the 2015 ACC AHA SKY-focused update on primary percutaneous coronary intervention for patients with ST elevation myocardial infarction, which I will be referring to as the 2015 PCI Focus Update, the 2016 ACC AHA Guideline Focus Update on duration of dual antiplatelet therapy in patients with coronary artery disease, which I'll be referring to as the 2016 DAPT Focus Update, and the 2021 ACC AHA SKY Guideline for coronary artery revascularization, which I'll be referring to as the 2021 Revascularization Guideline. I'm going to do a deep dive on 4 key pillars that were updated this year. 1. Revascularization strategy. 2. Dual antiplatelet therapy. 3. Lipid management. And 4. Mechanical circulatory support. Let's start with revascularization strategy. Previously, the 2021 Guideline for Revascularization said, in selected hemodynamically stable patients with STEMI and multi-vessel disease, after successful primary PCI, stage PCI of a significant non-infarct artery stenosis is recommended to reduce the risk of death or MI. That was a Class 1 recommendation. The 2025 guideline says, in selected hemodynamically stable patients with STEMI and multi-vessel disease, after successful PCI of the infarct-related artery, PCI of significantly stenosed non-infarct-related arteries is recommended to reduce the risk of death or MI and improve angina-related quality of life. Why? Because recent studies suggest a lower risk of MACE, predominantly driven by a lower rate of recurrent ischemia and recurrent MI, when multi-vessel stenting occurs as a single procedure as opposed to when staged. The guideline made this recommendation on the basis of the PRAMI trial and the COMPLETE trial. The PRAMI trial, which stands for Preventive Angioplasty and Acute Myocardial Infarction, randomized patients with STEMI and multi-vessel disease to complete revascularization versus culprit artery-only revascularization. The PRAMI trial was stopped early due to a significant reduction in the primary composite endpoint of cardiovascular death, non-fatal MI, or refractory angina, with complete revascularization, with significant reductions in non-fatal MI and refractory angina and a trend in reduction in the rates of cardiovascular death. The COMPLETE trial, which stands for Complete versus Culprit-Only Revascularization Strategies to Treat Multi-Vessel Disease After Early PCI for STEMI, randomized patients with STEMI and significant multi-vessel disease to stage PCI of the non-infarct-related artery, performed up to 45 days post-MI, or culprit vessel-only revascularization with PCI reserved for patients with refractory symptoms. At a median follow-up of 3 years, multi-vessel PCI reduced cardiovascular death or MI and cardiovascular death, MI or ischemia-driven revascularization. This benefit was consistent across all subgroups. Of course, the benefits of complete revascularization with multi-vessel PCI should not be extrapolated to patients with disease more suited to CABG surgery because they were excluded from these trials. Next, previously, the 2015 Focus Update on PCI for STEMI said, PCI of a non-infarct artery may be considered in selected patients with STEMI and multi-vessel disease who are hemodynamically stable, either at the time of primary PCI or as a planned stage procedure. That was a Class 2B recommendation at the time. For the non-infarct lesions, The 2025 guideline no longer considers stage revascularization to be the same as revascularization at the time of primary PCI. The latter is given a gentle bump up, although the overall recommendation remains weak as a Class 2B recommendation. Specifically, the 2025 guideline says, in selected hemodynamically stable patients with STEMI and low-complexity multivessel disease, those not intended for CABG surgery, multivessel PCI of significantly stenosed non-infarct-related arteries at the time of primary PCI may be preferred over a staged approach to reduce the risk of cardiovascular events. That is a Class 2B recommendation this year. What is the rationale for this? Performing multivessel PCI at the time of primary PCI offers the convenience of a single procedure, allowing for faster recovery without the risk of repeated arterial access or the potential for recurrent ischemia before the staged PCI occurs weeks later. The guideline made this recommendation on the basis of the results of the BioVasc trial and the multi-stars AMI trial. The BioVasc trial, which stands for Direct Complete versus Stage Complete Revascularization in Patients Presenting with Acute Coronary Syndromes and Multivessel Disease, randomized patients with ACS, including 40% with STEMI and multivessel disease, to a strategy of a single-setting immediate multivessel PCI or staged multivessel PCI. At 1 year, immediate multivessel PCI was non-inferior to staged multivessel PCI for the primary endpoint all-cause death, MI, unplanned ischemia-driven revascularization or cerebrovascular events. When compared with staged PCI, a single procedure multivessel PCI was associated with lower rates of recurrent MI and lower rates of unplanned ischemia-driven revascularization. The related multi-stars AMI trial, which stands for Multivessel Immediate versus Staged Revascularization in Acute Myocardial Infarction, compared a strategy of single procedure multivessel PCI with staged multivessel PCI in patients with STEMI and multivessel disease. Immediate multivessel PCI was non-inferior and superior to staged multivessel PCI for the primary endpoint of death, reinfarction, stroke, unplanned ischemia-driven revascularization, or hospitalization for heart failure at 1 year. This was largely driven by a lower rate of recurrent ischemia and recurrent infarction in the immediate group. In a network meta-analysis comparing all strategies for managing the non-infarct-related artery, a single procedure approach for the immediate multivessel PCI was preferred, followed by staged multivessel PCI. What do they mean by patients who are ideally suited for immediate complete revascularization? They are referring to patients with uncomplicated PCI of the infarct-related artery and low-complexity non-infarct-related artery disease with stable hemodynamics, normal LV filling pressures, and normal renal function. So these are a lot of caveats. Now, the above statements were for STEMI. What about NSTEMI? Previously, the wisdom to revascularize non-infarct lesions was only for STEMI and weaker in NSTEMI. Now they have upgraded the recommendation to encourage revascularizing non-infarct lesions in NSTEMI. The 2014 NSTEMI guideline previously said, a strategy of multivessel PCI in contrast to culprit lesion-only PCI may be reasonable in patients undergoing coronary vascularization as part of treatment for NST elevation ACS. That was a Class 2B recommendation at the time. The 2025 guideline says, in stable patients with NST elevation ACS with multivessel disease but without left main stenosis who are not intended for CABG surgery and undergoing culprit lesion PCI of significant non-culprit lesions at the time of the index procedure or as a stage procedure is recommended to reduce the risk of MACE. That's a Class 1 recommendation. So note that not only have they upgraded the recommendation to encourage revascularizing non-infarct lesions in NSTEMI, they have updated the class of recommendation from 2B to 1. Also, pay attention to the fact that the 2025 guideline says that in NSTEMI, you can revascularize the non-culprit lesions either at the time of the index procedure or as a stage procedure. But For STEMI, revascularization of the non-infarct lesions at the time of index PCI is preferred over a staged approach to reduce the risk of cardiovascular events in patients who are ideally suited for immediate complete revascularization, namely patients with uncomplicated PCI of the infarct-related artery and low-complexity non-infarct-related artery disease with stable hemodynamics, normal LV filling pressures, and normal renal function. Again, lots of caveats for that statement. When it comes to PCI of non-infarct lesions in patients who present with cardiogenic shock, the guidance remains the same as before. The 2021 guideline for revascularization had previously said, in patients with STEMI complicated by cardiogenic shock, routine PCI of a non-infarct artery at the time of primary PCI should not be performed because of the higher risk of death or renal failure. That was a Class 3 recommendation, harm. The 2025 guideline still says the same thing. In patients with STEMI complicated by cardiogenic shock, routine PCI of a non-infarct-related artery at the time of primary PCI should not be performed because of the higher risk of death or renal failure. Class 3, harm. The guideline made this recommendation on the basis of the results of the culprit shock trial. The culprit shock trial, which stands for culprit lesion-only PCI versus multivessel PCI and cardiogenic shock, randomized patients with acute MI, approximately 60% with STEMI and cardiogenic shock, to a strategy of complete multivessel PCI or culprit vessel-only PCI. At 30 days and 1 year, the rates of death or need for renal replacement therapy were significantly higher in the group of patients randomized to multivessel PCI. That being said, it should be noted that the culprit shock trial only permitted enrollment if there was an identifiable culprit lesion. In situations where an unstable appearing non-culprit artery lesion was observed, or in those patients with an uncertain culprit lesion, the decision to proceed with multivessel PCI may be more nuanced. For NSTEMI, the 2021 revascularization guideline had previously said, in patients with NST elevation ACS who present in cardiogenic shock, routine multivessel PCI of non-culprit lesions in the same setting should not be performed. That was a Class 3 recommendation, harm. The 2025 guideline still says the same thing. In patients with NST elevation ACS complicated by cardiogenic shock, routine PCI of a non-culprit artery at the time of index procedure should not be performed because of the higher risk of death or kidney failure. That is a Class 3 recommendation, harm. That covers the updates regarding revascularization strategy. We'll now move on to the second pillar of updates regarding dual antiplatelet therapy. The 2016 focus update on DAPT said in patients with ACS, whether it's NST elevation ACS or STEMI, treated with DAPT after BMS or DES implantation, P2Y12 inhibitor therapy, such as clopidogrel, prasugrel, or ticagrelor, should be given for at least 12 months. That was a Class 1 recommendation at the time. The 2025 guideline made minimal changes to this one. In patients with ACS who are not at high bleeding risk, DAPT with aspirin and an oral P2Y12 inhibitor should be administered for at least 1 year to reduce MACE. That still remains a Class 1 recommendation. Regarding the choice of DAPT agent, the 2016 focus update on DAPT said, in patients with ACS, whether it be NST elevation ACS or STEMI, treated with DAPT after coronary stent implantation, it is reasonable to use ticagrelor in preference to clopidogrel for maintenance of P2Y12 inhibitor therapy. At the time, that was a Class 2A recommendation. The 2025 guideline has bumped this preference up from Class 2A to Class 1 in 2 statements. In patients with NST elevation ACS undergoing PCI, prasugrel or ticagrelor is recommended to reduce MACE and stent thrombosis. That's a Class 1 recommendation now. In patients with STEMI managed with primary PCI, prasugrel or ticagrelor should be administered to reduce MACE and stent thrombosis. That is also a Class 1 recommendation now. Next, regarding early de-escalation from dual antiplatelet therapy to single antiplatelet therapy, or SAPT, the 2021 revascularization guideline had said, in selected patients undergoing PCI, shorter duration DAPT of 1 to 3 months is reasonable, with subsequent transition to P2Y12 inhibitor monotherapy to reduce the risk of bleeding events. That was a Class 2A recommendation at the time. The 2025 guideline refines the transition period from 1 to 3 months to 1 month. It also specifically suggests ticagrelor as a monotherapy agent instead of clopidogrel or prasugrel in this situation, and bumps this up from Class 2A to Class 1. It says, in patients with ACS who have tolerated DAPT with ticagrelor, transition to ticagrelor monotherapy for at least 1 month post-PCI is useful to reduce bleeding risk. That's a Class 1 recommendation. Results from several randomized trials, including Twilight ACS, Ultimate DAPT, TPAS, and TICO, have consistently shown that in patients who underwent PCI for ACS, after 1 to 3 months of ticagrelor-based DAPT, aspirin withdrawal followed by ticagrelor monotherapy results in less bleeding without clear excess in MACE as compared with continued DAPT. Although studies examining this strategy were previously critiqued for having relatively low rates of ischemic events, meta-analyses conducted at a study level and individual patient level pooled across studies have yielded similar results. The guideline specifically recommends ticagrelor as a monotherapy agent because results for clopidogrel as monotherapy have been mixed. The STOP-DAPT-2 ACS trial showed that de-escalating from DAPT to clopidogrel monotherapy at 1 to 2 months is associated with increased risk of MACE compared to continued DAPT. Some have posited that this excess thrombotic risk might be due to patient heterogeneity in inadequate platelet inhibition to clopidogrel, observed in 30% to 40% of patients after PCI. Although the on-treatment pharmacodynamic effects of ticagrelor and prasugrel are similar, the safety of prasugrel monotherapy has not been established in patients 1 month on post-ACS, so the guideline does not explicitly mention prasugrel as a monotherapy option. Next, regarding patients who undergo PCI for ACS but who have high bleeding risk, the 2016 Focus Guideline Update on DAPT said, in patients with ACS treated with DAPT after DES implantation who develop a high risk of bleeding, for example, treatment of oral anticoagulant therapy, or are at high risk of severe bleeding complications such as intracranial surgery, or develop significant overt bleeding, discontinuation of the P2Y12 inhibitor therapy after 6 months may be reasonable. That was a Class 2B recommendation. The 2025 guideline updates this by allowing the single antiplatelet agent to either be aspirin or P2Y12 inhibitor, and has brought forward the transition time from DAPT to single antiplatelet therapy from 6 months down to 1 month. In patients with ACS undergoing PCI who are at high bleeding risk, transition to single antiplatelet therapy, aspirin or P2Y12 inhibitor, after 1 month may be reasonable to reduce bleeding risk. That is a Class 2B recommendation in this year's guidelines. In the MASTER DAPT trial, which stands for Management of High Bleeding Risk Patients Post-Bioresorbable Polymer-Coated Stent Implantation with an Abbreviated versus Standard DAPT regimen, patients at high risk of bleeding who had completed a 4-week course of DAPT after successful PCI with drug-eluting stents were randomly allocated to single antiplatelet therapy or more prolonged DAPT, defined as at least 2 additional months of DAPT. Compared with standard therapy, an abbreviated antiplatelet strategy demonstrated non-inferiority with respect to composite ischemic events and superiority regarding clinically relevant bleeding over 1 year. Of note, in the absence of oral anticoagulant use, the choice of discontinuing aspirin or P2Y12 inhibitor and the choice of P2Y12 inhibitor was at the discretion of the treating physician. Although the trial demonstrated non-inferiority for abbreviated DAPT with respect to MACE in patients at high bleeding risk, it was underpowered to determine the relative safety of discontinuing aspirin versus P2Y12 inhibitor. Note that there are 2 statements here because one is going from dual antiplatelet therapy to single antiplatelet therapy, and the other is going from a stronger P2Y12 inhibitor to a less strong P2Y12 inhibitor. Specifically, the 2025 guideline says, in patients with ACS undergoing PCI, the escalation of DAPT, switching from ticagrelor or prasugrel to clopidogrel, after 1 month may be reasonable to reduce the bleeding risk. That's a Class 2B recommendation. This de-escalation from higher to lower intensity P2Y12 inhibitor can be guided by the results of platelet function assays that quantify the degree of platelet inhibition among patients treated with clopidogrel. Patients with adequate response may continue to receive clopidogrel, whereas non-responders are switched to a more potent P2Y12 inhibitor. Clopidogrel responsiveness may also be inferred with use of genotyping assays that identify polymorphisms in genes involved in clopidogrel metabolism. However, clinical trials examining the escalation of P2Y12 inhibitor intensity after PCI have either shown lack of benefit, as in the Antarctic trial, non-inferiority, as in the tropical ACS trial, or reductions in minor bleeding, as in the popular genetics trial. Because of the mixed nature of these results, guided de-escalation of P2Y12 inhibitor intensity is not explicitly recommended in the 2025 guideline. In contrast, unguided de-escalation refers to P2Y12 intensity de-escalation that is performed without antecedent knowledge of platelet responsiveness. The Topic and Taylor's AMI trials suggested that unguided de-escalation of P2Y12 inhibitor intensity 1 month after PCI reduces bleeding without incurring ischemic risk compared with longer-term prasugrel or ticagrelor-based DAPT. Meanwhile, the Triton-TIMI and Pegasus-TIMI trials suggested that the benefit of more potent P2Y12 inhibitor therapy extends beyond the early phase post-ACS, but with increased bleeding. Because of the mixed nature of these results, unguided de-escalation of P2Y12 inhibitor intensity has a weak 2B recommendation in the 2025 guidelines. Next, patients after ACS may frequently have indications for anticoagulant therapy, including atrial fibrillation, venous thromboembolism, and prosthetic heart valves. Regarding the duration of triple therapy in patients who are already on an antithrombotic agent, the 2014 NSTEMI guideline said the duration of triple antithrombotic therapy with a vitamin K antagonist, aspirin, and a P2Y12 receptor inhibitor therapy in patients with NST elevation ACS should be minimized to the extent possible to limit the risk of bleeding. That was a Class 1 recommendation. The 2025 guideline now explicitly suggests a transition time and also suggests which P2Y12 inhibitor to use. In patients with ACS who require oral anticoagulant therapy, aspirin should be discontinued after 1 to 4 weeks of triple antithrombotic therapy, with continued use of P2Y12 inhibitor, preferably clopidogrel, and oral anticoagulant to reduce bleeding risk. That is a Class 1 recommendation. Several randomized trials have demonstrated that a discontinuation of aspirin 1 to 4 weeks after PCI reduces the risk of bleeding in patients with atrial fibrillation and an indication for DAPT and an oral anticoagulant, including Read-Weill PCI, Pioneer AFib PCI, and Augustus. Although individual studies were not powered for ischemic endpoints, meta-analyses across the randomized trials suggest no difference in mortality, stroke, and overall MACE when aspirin is discontinued for patients on an oral anticoagulant, albeit with a marginal apparent increase in MI and stent thrombosis. Reflecting the fact that some trials gave triple therapy for 1 week while others gave triple therapy for 4 weeks, the guideline does not explicitly dictate whether to go with 1 week or 4 weeks. It says that in patients with a high risk of stent thrombosis, triple therapy with aspirin for up to 30 days after PCI could be considered. P2Y12 inhibitor therapy should be continued for at least 12 months after PCI following aspirin discontinuation, but could be discontinued earlier in those with multiple risk factors for bleeding. Regarding which P2Y12 inhibitor agent to use alongside an antithrombotic agent, trials of more potent P2Y12 inhibitors such as prasugrel or ticagrelor excluded patients requiring long-term anticoagulant. Therefore, clopidogrel is generally favored as the P2Y12 inhibitor in this setting for most patients who require an antithrombotic. I will close off this section by giving you the flow chart. For patients with ACS, the default strategy for DAPT is at least 12 months of DAPT, with ticagrelor or prasugrel being preferred post-PCI. That's a Class 1 recommendation. For patients with high bleeding risk post-PCI for ACS, either the aspirin or P2Y12 inhibitor can be stopped at 1 month, transitioning to single antiplatelet therapy using either the remaining aspirin or P2Y12 inhibitor. That is a Class 2B recommendation. For ACS patients, post-PCI in general, it is okay to transition from dual antiplatelet therapy to single antiplatelet therapy, but the monotherapy agent used during the period of single antiplatelet therapy should be ticagrelor specifically. That's a class 1 recommendation. Doing an unguided de-escalation of P2Y12 inhibitor therapy from aspirin plus ticagrelor or prasugrel to aspirin plus clopidogrel is also something that can be considered. That's a class 2B recommendation. For ACS patients who need to be on an antithrombotic, triple therapy with the antithrombotic, P2Y12 inhibitor, and aspirin can be transitioned to single antiplatelet plus antithrombotic anywhere between 1 to 4 weeks post-PCI, and clopidogrel is recommended as this antiplatelet agent in conjunction with antithrombotic. That's a class 1 recommendation. That covers the major updates regarding DAPT, which is the second pillar of updates in this year's guidelines. Next, we'll move on to the third pillar of updates, which is lipid management. This time, I will start by giving you the flow chart, then I will go through the individual statement updates and why they made them. For every patient hospitalized with ACS, if the patient is not on a statin yet, or if they are on only a low intensity or moderate intensity statin, then initiate high-intensity statin. That's a class 1 recommendation. Consider concurrent addition of ezetimibe. That's a class 2B recommendation. If the patient is already on a maximally tolerated statin regimen, if the LDL is 70 milligrams per deciliter or higher, add a non-statin therapy. That's a class 1 recommendation. If the LDL is 55 to 69 mg per dil, consider adding a non-statin LDL lowering therapy. That's a class 2A recommendation. If the LDL is less than 55 mg per dil, then there's nothing to add, just continue the statin. That's a class 1 recommendation. If the patient is statin intolerant or declines to take a statin, add a non-statin LDL lowering therapy. That's a class 1 recommendation. For all of the above, you should reassess the lipid profile in 4 to 8 weeks after discharge and adjust therapy as needed to achieve lipid targets. That's a class 1 recommendation. Now let's dive into each of these recommendations and why they made them. The 2025 ACS Guidelines first statement about lipids is just a minor rewording from the prior 2014 NSTEMI Guideline, 2013 STEMI Guideline. High-intensity therapy should be initiated or continued in all patients with STEMI or NST elevation ACS and no contraindications to use. This was the wording from both the 2013 STEMI Guidelines and 2014 NSTEMI Guidelines, Class 1 for both. The 2025 Guidelines minor wording update is as follows. In patients with ACS, high-intensity statin therapy is recommended to reduce the risk of MACE. That's a Class 1 recommendation. The 2025 ACS Guideline makes 4 statements about lipids that had no corresponding statement in the earlier guidelines about ACS. First, in patients with ACS who are already on maximally tolerated statin therapy with low-density lipoprotein cholesterol of at least 70 milligrams per dil or higher, which corresponds to at least 1.8 millimoles per liter, adding a non-statin lipid-lowering agent is recommended to further reduce the risk of MACE. That's a Class 1 recommendation. Non-statin lipid-lowering agents include ezetimibe, evolocumab, alirocumab, inclisiran, and bempedoic acid. Most of these medications were not routinely available at the time of the prior guidelines. The 2025 guideline notes that inclisiran lowers LDL levels by 50%, but clinical outcome studies were still pending at the time of guideline writing. Second, in patients with ACS who are statin intolerant, non-statin lipid-lowering therapy is recommended to lower LDL and reduce the risk of MACE. That's a Class 1 recommendation. To consider a patient as having statin intolerance, a minimum of 2 statins should be attempted, including at least 1 at the lowest approved daily dose. As I mentioned, non-statin lipid-lowering therapies including ezetimibe, evolocumab, alirocumab, inclisiran, and bempedoic acid. For details on each of these medications, please listen to my Season 2 episode 2.01 on ASCVD risk estimation and lipid lowering. Third, in patients with ACS, the concurrent initiation of ezetimibe in combination with maximally tolerated statin may be considered to reduce the risk of MACE. That's a Class 2B recommendation. This 2B recommendation is supported by the results of the IMPROVE-IT trial, which studied the combination of simvastatin versus simvastatin and placebo, which is simvastatin monotherapy, in patients hospitalized with an ACS in the past 10 days. The addition of ezetimibe reduced the relative risk of MACE by 6.4% compared with placebo, with a hazard ratio of 0.936 over a median of 6 years follow-up. Fourth, in patients with ACS who are already on maximally tolerated statin therapy with LDL cholesterol of 55 to 69, corresponding to 1.4 to 1.8 millimoles per liter, adding a non-statin lipid-lowering agent is reasonable to reduce the risk of MACE. That's a Class 2A recommendation. Prior to this guideline, no guideline explicitly addressed a population of patients who were already at an LDL level of 55 to 69 mg per dil at the time of ACS. This is a recommendation supported by the fact that in Improve It, which randomized patients post-ACS with LDL levels between 50 and 125 mg per dil to simvastatin and ezetimibe versus simvastatin placebo, the benefit of ezetimibe addition in the post-ACS period was similar among patients with LDL of 50 to 70 mg per dil versus more than 70 mg per dil. The PCSK9 inhibitor trials Fourier and Odyssey outcomes enrolled patients with LDL cholesterol of at least 70 mg per dil and thus did not specifically assess outcomes associated with addition of PCSK9 inhibitor therapy among patients with LDL levels 55 to 70 mg per dil. However, secondary analyses of both Fourier and Odyssey showed better outcomes in patients with achieved LDL of less than 50 mg per dil versus those with achieved LDL levels of more than 50 mg per dil inclusive, with monotonic relationships suggesting better outcomes with progressively lower LDL, even well below 50 mg per dil. That covers the updates regarding lipid management. Now we'll move on to the last pillar of updates, mechanical circulatory support. The 2025 guideline includes a new recommendation about using the Impella or microaxial flow pump device in cardiogenic shock. Cardiogenic shock is a core part of the ACS guidelines, as cardiogenic shock comprises 10% of patients with STEMI and has an early mortality rate of 40% to 50%. Impella was not explicitly mentioned in the 2013 STEMI guideline or the 2014 NSTEMI guideline. Impella was mentioned indirectly in the 2021 revascularization guideline, but for a different indication, i.e. for complex PCI. Specifically, the 2021 revascularization guideline said, in selected high-risk patients, elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise during PCI. The 2025 guideline explicitly mentions Impella. It says, in selected patients with STEMI and severe or refractory cardiogenic shock, insertion of a microaxial intravascular flow pump is reasonable to reduce death. This comes with a Class 2B recommendation. The 2025 guideline made this 2B recommendation on the basis of the DanGer Shock trial. Previously, small studies of Impella did not demonstrate clinical benefit for patients with acute MI and cardiogenic shock, including the ISAR Shock trial, which was efficacy study of LV assist device to treat patients with cardiogenic shock, the IMPRESS and severe shock trial, which was Impella versus IABP reduces mortality in STEMI patients treated with primary PCI and severe cardiogenic shock, and the Impella stick trial, which was Impella Programme de soutien aux techniques innovantes et coûteuses. The DanGer Shock trial, which stands for the Danish-German Cardiogenic Shock Trial, at 14 centers across Europe, enrolled patients with STEMI and cardiogenic shock of less than 24 hours duration, and randomized them to use of a microaxial flow pump or standard of care. Use of a microaxial flow pump significantly reduced the risk of all-cause mortality at 180 days by 26%, which corresponded to a hazard ratio of 0.74 and a number needed to treat of 8. However, although there was a mortality benefit, the class of recommendation is still limited at 2B due to the increased risk of serious complications like bleeding, limb ischemia, and renal replacement therapy with the Impella seen in the DanGer Shock trial. Therefore, use of an Impella is reasonable to reduce mortality in patients with STEMI and cardiogenic shock who have clinical features consistent with the inclusion criteria of the Danger Shock trial. What are these criteria? Cardiogenic shock was defined as hypotension, that's systolic blood pressure less than 100 millimeters of mercury or vasopressor support, and organ hypoperfusion, defined as arterial lactate of at least 2.25 millimoles per liter, and SvO2 less than 55% with a normal PaO2, and LV ejection fraction less than 45%. Patients who were comatose, meaning Glasgow Coma Scale score of less than 8, after out-of-hospital cardiac arrest, and patients with overt right ventricular failure were excluded. Patients with STEMI who present with SCAI shock stages C, D, or E, who are non-comatose and have adequate peripheral vasculature to accommodate large bore access, are reasonable candidates for the microaxial flow pump. The timing of Impella placement was not specified by the trial protocol, so the preferred timing of Impella placement is unclear. Overall, more data are needed to guide the selection of patients for mechanical circulatory support, the timing of MCS placement and duration support, and strategies to reduce the risk of vascular complications, bleeding, and limb ischemia. Apart from the new statement about Impella, the 2025 guideline also includes a statement recommending against the use of routine balloon pump and VA-ECMO in acute MI and cardiogenic shock. Specifically, it says in patients with acute MI and cardiogenic shock, the routine use of IABP and veno-arterial extracorporeal membrane oxygenation, or VA-ECMO, is not recommended due to a lack of survival benefit, Class 3. Previously, the 2013 STEMI guideline had said the use of an intra-aortic balloon pump is reasonable in patients with cardiogenic shock after STEMI who do not quickly stabilize with pharmacologic therapy. At the time was a Class 2A statement rather than the new Class 3 statements, no benefit. Previously, the 2015 AHA scientific statement on mechanical circulatory support had said VA-ECMO can be considered in patients with refractory cardiogenic shock. However, there is a paucity of randomized clinical trial data to support its routine use. No class of recommendation was given since this was a scientific statement instead of a guideline. The 2025 guideline made the Class 2 recommendation of a balloon pump on the basis of the results of the IABP SHOCK 2 trial. The IABP SHOCK 2 trial, which stands for Intra-Aortic Balloon Pump and Cardiogenic Shock 2 trial, randomized patients with acute MI and severe or refractory cardiogenic shock in whom revascularization was planned to IABP or no IABP. At 30 days and at 6 years of follow-up, no differences were observed between the IABP and no IABP arm in the primary outcome of all-cause death, nor were there differences in recurrent myocardial infarction, stroke, or repeat revascularization, rehospitalization for cardiac reasons, or even in quality of life. The guideline made the Class 2 recommendation about VA-ECMO on the basis of the results of the ECMO CS and ECLS shock trials. The ECMO CS trial, which stands for extracorporeal membrane oxygenation in the therapy of cardiogenic shock, randomized patients with rapidly deteriorating or severe cardiogenic shock to immediate or no immediate VA-ECMO. At 30 days, no differences were observed in the primary composite endpoint of all-cause death, resuscitated cardiac arrest, and implementation of another MCS device. The ECLS shock trial, which stands for extracorporeal life support in infarct-related cardiogenic shock, randomized patients with AMI and severe or refractory cardiogenic shock in whom early revascularization was planned to early ECLS or no ECLS. No differences were observed between the ECLS versus no ECLS arm in the primary outcome of the 30-day mortality rate or secondary outcomes. Moderate or severe bleeding and peripheral vascular complications requiring intervention were higher in the ECLS versus no ECLS arm. Overall, VA-ECMO has not been shown to reduce death compared with medical therapy alone in patients with cardiogenic shock in the setting of MI, but increases major bleeding and vascular complications. So, if balloon pump and VA-ECMO are no longer recommended for routine use in acute MI with cardiogenic shock, what other situations are we still allowed to use it in? There are 3 clinical scenarios in which balloon pump use is still supported by the current guidelines from the AHA, ACC, SCAI, or HFSA. Scenario 1. Per the 2021 Revascularization Guideline, In selected high-risk patients, elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonable to prevent hemodynamic compromise during PCI. That was a Class 2B recommendation. That being said, this statement mainly applies to Impella. As the 2021 guideline notes, intra-aortic balloon pump counterpulsation provides minimal hemodynamic support for PCI, but improves coronary and cerebral perfusion. Scenario 2. Per the 2022 heart failure guideline, in patients with advanced HFrEF and hemodynamic compromise and shock, temporary MCS, including percutaneous and extracorporeal ventricular assist devices, are reasonable as a bridge to recovery or bridge to decision. That was a Class 2A recommendation. Scenario 3. Per the 2025 ACS guideline, in patients with mechanical complication of ACS, short-term MCS devices are reasonable for hemodynamic stabilization as a bridge to surgery. That is a Class 2A recommendation. There are two clinical scenarios in which VA-ECMO use is still supported by current guidelines from the AHA, ACC, SCI, HFSA, albeit in a limited and reserved manner. Scenario 1. Per the 2022 heart failure guideline, in patients with advanced HFrEF and hemodynamic compromise and shock, temporary MCS, including percutaneous and extracorporeal ventricular assist devices, are reasonable as a bridge to recovery or bridge to decision. That's a Class 2A recommendation. Scenario 2. Per the 2020 resuscitation guideline, there is insufficient evidence to recommend the routine use of extracorporeal CPR for patients with cardiac arrest. ECPR may be considered for select cardiac arrest patients for whom the suspected cause of cardiac arrest is potentially reversible during a limited period of mechanical cardiorespiratory support. That's a Class 2B recommendation. That covers the last pillar of updates, which is regarding mechanical circulatory support. Let's close with the 10 take-home messages. The 2025 guideline writers offer 10 take-home messages. 4 of these take-home messages are regarding other topics that I shall not expound on here as they are relatively uncontroversial, but you should still be aware of them. First, red blood cell transfusion to maintain a hemoglobin of 10 grams per liter may be reasonable in patients with ACS and acute or chronic anemia who are not actively bleeding. Second, 2 procedural strategies are recommended in patients with ACS who are undergoing PCI. A. Radial approach is preferred over femoral approach in patients with ACS undergoing PCI to reduce bleeding, vascular complications, and death. And B. Intracoronary imaging is recommended to guide PCI in patients with ACS with complex coronary lesions. Third, in patients with non-ST segment elevation ACS who are at intermediate and high risk of ischemic events, an invasive approach with the intent to proceed with revascularization is recommended during hospitalization to reduce major adverse cardiovascular events. In patients with non-ST elevation ACS who are at low risk of ischemic events, a routine invasive or selective invasive approach with further risk stratification is recommended to help identify those who may require revascularization and to reduce major adverse cardiovascular events. Fourth, after discharge, focus on secondary prevention is fundamental. A fasting lipid panel is recommended 4 to 8 weeks after initiating or adjusting dose of lipid-lowering therapy. Referral to cardiac rehabilitation is also recommended with the option of home-based programs for patients unable or unwilling to attend in person. Finally, let's cap off by going over the 6 major take-home messages. To summarize, the guidelines made changes in 4 main topics. The take-home message for revascularization is as follows. A strategy of complete revascularization is recommended in patients with ST elevation myocardial infarction or non-ST segment elevation ACS. The choice of revascularization method, i.e. CABG versus multivessel PCI in non-ST elevation ACS and multivessel disease, should be based on the complexity of the coronary artery disease and comorbid conditions. PCI of significant non-culprit stenosis for patients with ST elevation myocardial infarction can be performed in a single procedure or staged procedure with some preference towards performing multivessel PCI in a single procedure. In patients with ACS and cardiogenic shock, emergency revascularization of the culprit vessels indicated. However, routine PCI of non-infarct-related arteries at the time of PCI is not recommended in these cardiogenic shock patients. The take-home message for DAPT is as follows. Dual antiplatelet therapy is recommended for patients with ACS. Ticagrelor or prasugrel is recommended in preference to clopidogrel in patients with ACS who are undergoing percutaneous coronary intervention. In patients with NSTEMI who are scheduled for an invasive strategy with timing of angiography to be more than 24 hours, upstream treatment with clopidogrel or ticagrelor may be considered to reduce major adverse cardiovascular events. DAPT with aspirin and an oral P2Y12 inhibitor is indicated for at least 12 months as a default strategy in patients with ACS who are not at high bleeding risk. Several strategies are available to reduce bleeding risk in patients with ACS who have undergone PCI and require antiplatelet therapy. A. In patients at risk for gastrointestinal bleeding, a proton pump inhibitor is recommended. B. In patients who have tolerated DAPT with ticagrelor, transition to ticagrelor monotherapy is recommended at approximately 1 month after PCI. And C. In patients who require long-term anticoagulation, aspirin discontinuation is recommended 1 to 4 weeks after PCI with continued use of a P2Y12 inhibitor, preferably clopidogrel, in conjunction with the long-term anticoagulant. The take-home message for lipid management is high-intensity statin therapy is recommended for all patients with ACS and with the option to initiate concurrent ezetimibe, a non-statin lipid-lowering agent, for example, ezetimibe, evolocumab, alirocumab, inclisiran, or bempedoic acid, is recommended for patients already on maximally tolerated statin who have an LDL of still more than 70 mg/dL. It is reasonable in this high-risk population to further intensify lipid-lowering therapy if the LDL is not yet below 55 and the patient is already on a maximally tolerated statin. Lastly, the take-home message for Impella is as follows. Based on one trial, use of the microaxial flow pump in selected patients with cardiogenic shock related to acute MI is reasonable to reduce death. However, complications such as bleeding, limb ischemia, and renal failure are higher with the microaxial flow pump compared with usual care. Therefore, careful attention to vascular access and weaning of support is important to appropriately balance the risks and benefits. Okay, we've covered a lot today. I hope you found this granular comparison insightful. For every recommendation update, I've compared this year's guidelines with the specific phrasing from prior year's guidelines and also drawn in the trials that justify the new guidelines. I encourage anyone who has time to check out the full guideline at the AHA ACC Guideline Hubs. Thank you for joining me on a deep dive of this guideline.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.